Okay, good afternoon. Are you seeing my screen? Can you see my screen? Anyone, please answer.
Yes.
Okay, let's just wait for some so I don't have to think of admitting your classmates. Okay, if you're having trouble connecting to the Zoom call and you want to listen in to the lecture, you may view the live stream in my YouTube channel. Yeah, if you want to hear it clearer. Okay. Uh, I know we've had its instructions that we only accept enrolled students, but I don't mind you listen in on the lecture and you participate. But please do have an effort to enroll yourself so that you will not have any problem later on in the semester or the school year regarding your grades. All right? Is that clear? We'll wait a few minutes more so that your classmates could join. Please tell them to join so that we could start. Okay, for this afternoon, we will have preterm and postterm labor as our topic for the next at least hour or so. All right? So the contents of this lecture would be preterm, its definition, risk factors, diagnosis, investigations, prediction and preventions, how you treat, manage, and we look at preterm pre-labor rupture of membranes. For post-term, we look at, again, its introduction, significance, how we approach post-term labor, and management. Okay. So we first define definition. So by definition, your preterm pregnancy is any pregnancy that is less than 37 weeks age of gestation. So your term pregnancy is any gestation from 37 to 41 and 6 days age of gestation. And your postterm pregnancy will be any pregnancy that would be beyond 42 weeks and onwards. Okay? Fairly simple concept. Okay. So, according to definitions, your preterm labor is defined by the WHO as completion of 37 weeks in a pregnancy beyond 20 weeks of gestation. We all know that any gestation that's less than 20 weeks would be considered an abortion. And labor is defined less than 37 weeks with regular uterine contractions, and this is defined as 4 contractions in 20 minutes or 8 in 60 minutes, bringing about cervical change in cervical score in the form of an effacement of at least 80% or a cervical dilatation of more than 1 centimeters. So, labor should be contractions fulfilling the criteria. So, 4 in 20, 8 in 60. It brings about changes in your cervix, having an effacement of at least 80% and a dilation of more than 1 centimeters. Okay? These criterion will be clear. Okay. However, this condition tends to be overdiagnosed and overtreated. It's overdiagnosed and overtreated because we are very wary of preterm labor as an occurrence because it brings about a lot of morbidities and mortalities, especially for the fetus. So, preterm labor, nearly 50 to 60% of preterm births occur following spontaneous labor, and 30% would be due to preterm premature rupture of membranes, which is usually due to infection. The rest are iatrogenic or no reason could be found with regards to the cause. Okay? And we are very wary, as I've mentioned, because half of your neonatal morbidity would occur in preterm infants. So despite of all advances in the obstetric medical world and neonatal care for that matter, still there has been no decrease in incidence of preterm labor for the past half of a century. In fact, it's been increasing in development countries as there are more high risk pregnancies and more high risk mothers that actually try to get pregnant. Before, if you have heart disease, you don't try anymore. If you have other diseases, you don't try anymore. So, because of this, more incidence, a higher incidence of preterm births do occur. Okay? So, in 5 to 12% of all pregnancies and majority of deaths and nearly half of all cases, like cerebral palsy, preterm birth is there. Okay? By weight, so at a neonate that would be less than 1,000 to 1,500 grams would have at least compared to the 1960s would have already a greater chance of survival just because he or she was born in our time. So the focus then is shifting to early preterm birth that is less than 32 weeks, which account for 1 to 2% of all births, but contribute to 60% or more than half than perinatal mortality and nearly all neurological morbidity. So of course, increase in the numbers of multiple pregnancies secondary to artificial reproductive technology, fertility drugs, assisted reproduction are also major causes of increased incidence of preterm birth. Okay. So this would be mildly preterm is 32 to 36 weeks. So this would be the patients that would not really need surfactant. They are more than 1,500 in weight. So they just need to be monitored closely. Very preterm, 28 to 31, these are the ones with surfactant use, and extremely preterm, um, very few are viable, especially if it's less than 500 grams or less than 1,000 grams. So these are the different reasons why you could go into preterm delivery. So number one on this list would be infections. So any infection that would cause preterm pre-labor rupture of membranes or cause an increase in the WBC, which would cause the early rupture, is definitely to cause preterm labor. Okay? Overdistension, any higher order pregnancy, large for gestational age babies, you think preterm labor. Any vascular problem, hypertension, and the like, you think of any possibility of preterm labor. Of course, if you have to undergo surgical procedures and other illnesses, abnormal uterine cavity, which makes your uterine cavity smaller, hence more likely to be distended. Cervical weakness is also one, and idiopathic causes. Okay? So these are all the possible reasons why a mother, a pregnant patient would undergo preterm birth. So your risk factors could be classified into major non-modifiable and modifiable risks. So one of the major non-modifiable risks would be a history of previous pregnancy, preterm birth. So if you have a last birth preterm, it increases you with a risk of 20%. If you have had two previous preterm births, it increases your risk to 40%. Another non-modifiable would be your twin pregnancy, which increases your risk of preterm birth to 50%. And of course, your uterine or cervical anomalies and factors in current pregnancy. Non-modifiable but minor would be parity of any either a nulligravid or a multigravid would have higher risk of preterm birth. Ethnicity, they say black people have higher risk of preterm birth. For socioeconomic status, education, and teenagers having second or subsequent babies. Your modifiable, this would be your more or less lifestyle diseases or lifestyle causes of preterm birth. Smoking increases your risk to relative risk to 2 times. Drug abuse, especially cocaine. A BMI of less than 20 and less than a year interpregnancy interval. So you have your factors that are modifiable, major, and minor, and your non-modifiable lifestyle diseases. Okay? So usually this preterm birth would come to you with complaints of either cervical weakness or complaints leading to infection or abruption. So any symptom with cervical weakness would show vaginal discharge, mild abdominal pain, and bulging membranes upon examination. If it shows infection, it would show systemic signs of infection, would have painful uterine contractions and abdominal pain. The criteria, of course, it should be dependent on the age of gestation. Again, uterine contractions, 3 in 30, 1 in 10. Cervical change in cervical dilatation or at least a 2 centimeters dilated cervix. So please remember this. I've repeated this all over again for the past slides. Age of gestation, the contractions bringing about cervical change. So differentials, you would think of UTI, myoma degeneration, abruptio, constipation, or gastroenteritis. But again, the mortality rate of preterm labor is such that slight complaint of the patient that the patient has abdominal pain, we do treat with low tolerance because we are wary of the consequences. So of course you have to have your history, examinations, and these are your further investigations. You have your CBC, CRP, these are for your infection and your WBC count, urine sample for UTI, ultrasound, transvaginal sonography, and fetal fibronectin. So let's look at them one by one. So prevention would be treatment of any discharge. So this is usually metronidazole, 500 milligrams BID. If you need to do cervical seclage, this is a procedure wherein you make purse-like strings, stitches on your cervix to prevent it from dilating. If you have a higher order pregnancy, others may do a selective reduction of pregnancy numbers. And the role of progesterone is becoming in the forefront that we give the progesterone as a means of support for the pregnancy to avoid preterm birth. Okay. So we look at cervical length. So normally, the length of the cervix is 3.5 centimeters. So in asymptomatic women with singleton pregnancy, a cervix that would be less than 15 millimeters long or less than 5 millimeters long would have a risk of delivering for before 32 weeks by 4% and 78% respectively. And look at this, symptomatic women with singleton pregnancy, less than 15 or greater than 15 risk of delivering within 7 days is 50%. As to those with greater than 50 millimeters, delivery is less than 1%. Okay? So your cervical length is very important when determining, when predicting your preterm birth to occur. Okay? Although this one would be not clinically useful because of the cost, fibronectin is a glue-like protein at choriodecidual interface. So this test offers rapid assessment of risk in symptomatic women with minimal cervical dilatation. It's not present in your vaginal secretions 22 to 36 weeks. So it's positive. Test indicates that women would be likely to deliver. It predicts preterm birth within 7 to 10 days of testing and implies that your choriodecidual interface is disrupted. Okay. So we have your tocolytic agents, and these would be used to prevent labor and delivery. So we prolong pregnancy but not more than 72 hours. So what we do is that we use it so that we could administer the surfactant or maternal steroids so that the lungs will mature and transport a mother to a facility with neonatal intensive care. So this would be the important tocolytic drugs. Magnesium sulfate would have a less role in your preterm birth. However, it's still given for your neuroprotective effect to prevent cerebral palsy. Its role in preterm birth has diminished because of the side effects of pulmonary edema, weakness, and respiratory depression. Okay. Another option would be beta-adrenergic agonist. This is your terbutaline. Side effects would be hypertension, hypokalemia, and hyperglycemia. This is the one that's widely used now. We give our calcium channel blockers that decreases intracellular calcium, hence decrease the contractions of the uterus. Nifedipine, we give it 30 milligrams initially as loading dose, then 10 milligrams every 8 hours. So, of course, it's a anti-hypertensive, hence side effects would be hypotension and myocardial depression. Okay? Another would be a prostaglandin synthetase inhibitor. So, again, it also decreases your smooth muscle contractility. And this would be indomethacin. So we have fetal complications like premature closure of your ductus, necrotizing enterocolitis, thus restricting their use. Hence, we often use calcium channel blockers and our beta adrenergic agonists. Okay. So we administer steroids. So it reduces the rate of respiratory distress, intraventricular hemorrhage, and neonatal death. And this is given as an IM injection, two doses 12 to 24 hours apart, and maximal benefit is seen after 48 hours. You either give dexamethasone or your betamethasone depending on what is available in your hospital pharmacy. So how we may manage? So confirm labor using the three criteria. Again, it's age of labor, contractions, and cervical change. So rule out any contraindication of tocolysis. Administer IV line. Okay, you start your magnesium sulfate for your neuroprotection, and then start your preterm labor medicines. Then you administer your steroids. Okay? Okay, so you have to have a clear plan about your mode of delivery, how you monitor, presence of a pediatrician, or antibiotics in labor. So your mode of delivery, if it is an impending, it is already dilated, you could go about your spontaneous vaginal delivery. If there are other reasons for termination of labor, then you do a cesarean section. And if your cervix is not yet right. So for preterm pre-labor rupture of membranes, it occurs before 37 weeks of gestation, and it complicates 3% of pregnancies and one-third of preterm births. So again, infection, multi-pregnancy, polyhydramnios, antepartum hemorrhage, abruption, cervical weakness, and idiopathic. Okay? So, of course, diagnosis would be a sudden escape of your amniotic fluid, and it shows oligo or anhydramnios on your ultrasound. So, your pooling of amniotic fluid in your posterior vagina, you could confirm by using a sterile speculum, and you look at the fluid that is coming out of the os. You could also do your nitrogen test, which turns blue from yellow if your amniotic fluid is leaking. Your Fern test also, you get a sample from your amniotic fluid, look under the microscope, and if there is ferning, then again amniotic fluid is present. Okay? So your ultrasound may show oligohydramnios or anhydramnios, which is less than 5 or any less than 2 centimeters deep pocket in your ultrasound. And your Amnisher test, which detects trace amounts of your placental microglobulin, and these are your options for diagnosis. So it needs to be differentiated from simple urinary incontinence and just a profuse normal vaginal discharge brought about by UTI or vaginal infection. Okay, prompt diagnosis is important so that we could manage it properly. So if you are preterm pre-labor but remote from term, conservative management is advisable. So you provide acute cord complications like prolapse and compression. You anticipate abruption and fetal distress should be excluded and ruled out. And oligohydramnios is not an indication. So give your antibiotics to have prolonged latency and improve outcomes, and give your corticosteroids. So induced labor unless your fetal lung maturity is doubtful. Remember, this is already ruptured membranes. So serial amnioinfusion for patients less than 26 weeks and severe oligo in selected women would reduce the risk of pulmonary hypoplasia and improve neonatal survival. Okay? So that is for preterm pregnancy. So for postterm pregnancy, it is any pregnancy that would exceed 42 weeks from the first day of last menstrual period in women with regular 28-day cycles. So it's also known as post-dated pregnancy and prolonged pregnancy. So incidence in postterm pregnancy is approximately 10%. So incidence is decreasing because of better estimation of duration of gestation and timely induction of labor. So past history of prolonged pregnancy is a risk factor. Family history, so in this case, for race, whites would have more tendency to have postterm pregnancy. If you have anencephaly, congenital adrenal hyperplasia, or extrauterine pregnancy. Okay. So your fetal complications would be two. It would either be a macrosomia syndrome or a dysmaturity syndrome. You have your maternal complications. Of course, your mother may be anxious, prolonged labor, and because of this anxiety, you may have higher incidence of cesarean section. Okay? So your macrosomia is placental function is maintained. It results in a healthy but large fetus. Your amniotic fluids normal, and the risk of cesarean section because of prolonged and arrested labor, and because of the large baby, you will have shoulder dystocia. This maturity, your placental function deteriorates, and your placental insufficiency results in reduction of your metabolic and respiratory support to the fetus. So your amniotic fluid is decreased. So usual indications for your cesarean section would be your non-reassuring fetal status or your oligohydramnios due to cord compression. Okay, these
Excuse
are
me,
your
doctor.
anxiety. So post-dated pregnancy because you're worried that you are more than your estimated due date. You know that the due date is equivalent to 40 weeks. So explain to your patient that you have 2 more weeks to go before you are actually post-term. So
Excuse me,
prolonged
doctor, I have
labor
a question.
increases significantly and also increases the risk of instrumental delivery as well as your cesarean section. So management, it depends on the confirmation of gestational age and the favorability of the cervix. So remember your Bishop score. What are the components of your Bishop score? Anyone?
Consistency, position, effacement, dilation, and station.
Bishop score is what? So it has to have be more than 8. So just look up the components to say that that your cervix is favorable. So in a book case confirmation, gestational age is easily determined if it's already your patient. If you are not sure of your patient and you haven't seen your patient's profile yet, it's hard to diagnose post-term pregnancy. So again, history, determining your last menstrual period and having an early ultrasound will be helpful. Family history and a history of neural tube defects. So your examination, as I've mentioned, your Bishop scoring. Okay. So your ultrasound and your NST and AFI. So your NST and your amniotic fluid index combined would be your modified biophysical profile. So your biophysical profile would usually include what? Your determining of your tone, fetal heart flexion, etc., etc., and it takes time. But your modified BPP just looks at your two components. It looks at a positive NST or a reactive NST and an AFI index that is within normal limits. Okay. So 50% of women that going beyond 42 weeks of gestation would eventually have spontaneous labor in 4 to 5 days. So don't um, hurry. So poor Bishop score, good fetal health, you could continue undergoing labor. Okay? So you are to induce when you have a favorable cervix. You have your oligo, you have your fetal macrosomia, non-reactive NST, then you are indicated to do induction of labor. So your induction of labor, you administer oxytocin, you administer your cervical ripening agents to hasten your delivery so that we could avoid complications of postterm delivery. Okay? So this would be introducing you to preterm and postterm delivery. Any questions?
Excuse me, doctor, I have a question. Uh, Doctor, what could be the reason that whites have a greater tendency to develop post-mature pregnancy? Like, is it because of some genetical conditions or the environment they are exposed to? So, like, what could be the probable reason?
Okay, any questions? If there are none, you may leave this call.
Okay, thank you, doctor.
Thank you for listening to this lecture.